morning, Zorana. Thank you very much for your invitations, and it's a really a big pleasure to be here with you today. I try to share my screen. Can you see my slides?
Mm-hmm. Yes.
Okay. So in my presentations, I'm going to briefly illustrate some data regarding the treatment of colorectal cancer in Italy. And the aim is to underline how proper health organizational models have a positive impact on the quality of colorectal cancer care, and how, on the contrary, the lack of dedicated centers can determine inequalities among patients. Epidemiologically, Italy, together with Spain, Portugal, Norway, Hungary, is a country with a high incidence of colorectal cancer, very similar to breast cancer. And we have about 50,000 new cases every year, and they represent 10% of all the new diagnoses in Europe. Then Italy has had national health systems since 1979. We have about 80% of hospital beds located in public hospitals and 20% in private hospitals. But then Italy is divided in 20 regions, and each region has its own regional health systems. And then there are around more than 600 local health districts. But since 2014, the Italian National Cancer Plan has been focusing on the concept of regional cancer networks, according to a sort of federal model. And the logic underpinning networks is that they could give the maximum support to patients suffering from cancer by making health services homogeneous in all Italian regions and increasing the standard of treatment. But recently, our government retired the organizational models to be included in our regional cancer network. And there are comprehensive cancer centers, the hub and spoke systems, the cancer care network, and finally the comprehensive cancer center network, which among all, it's the one probably that would have the best characteristics in terms of efficiency and also sustainability. And this is also the intentions of the European Union, because it has been confirmed in the latest cancer plan, where in addition to the four key actions areas, the preventions, the early detections, diagnosis and treatment, the improvement of quality of life, there are also 10 flagship initiatives. And one of these, the number 5, involves the establishment of a European network linking all the recognized comprehensive cancer centers in every member state. And the aim is to reduce the inequality among European citizens. But despite the good intentions, the reality in Italy at the moment is that there are only 7 out of 20 regional cancer networks. Only 7 are full active. And there are still many, in my opinion, too many hospitals that provide cancer care to about 3 million cancer patients. As you can see, more than 350 hospitals. And when it comes to many hospitals treating a specific tumor, the question is, what about their individual volume? And I mentioned the volume just because we know very well that there is a clear-cut associations between the 30-day mortality and the number of patients treated in each hospital. And the reason is that hospitals with a high caseload are able to treat postoperative complications if they occur. And this is an example of what can happen. These are data from our national outcome programs. It is an evaluation tool developed by the Ministry of Health just for national comparative evaluations of safety, efficiency, and quality of care without any ranking. As you can see, there is a huge variability in Italy in terms of volume. And the median volume in each region is well below what should be considered the minimum volume, 100 cases a year. Even if there are, as you can see, some hospitals that have a very high volume. As a consequence, also the 30-day mortality is considerably variable from region to region. And we are well aware that when it comes to mortality, even limited fluctuations in rate are sometimes unacceptable. So what I've just said become more evident if we look at the data at the regional level. This is the Lazio region where I work. And the Lazio region is the second region in terms of populations and the second region in terms of colorectal cancer incidence with approximately 5,000 cases a year. Well, in my region, there are over 7 hospitals that perform colorectal surgery. And I think that this picture is dramatic about the volume, because as you can see, we have only 5 hospitals with a volume exceeding 100 cases a year, and more than 50% hospitals treat less than 10 cases a year. And correspondingly, given that the average mortality rate is roughly 4%, in my opinion, a little bit high, most hospitals have a higher mortality rate. And I think that this is a very impressive example of inequality. And this happens also because there is a total lack of referral between district hospital, health districts and hospitals. On the right, on the left, you can see the health districts, 10 health districts in the Lazio regions, and on the right, the 30 public hospitals. You can see that the patient's flow seems to be absolutely random. And I think it's superfluous. I tell you that in Lazio region, cancer network has not still been activated. But on the basis of these considerations, I think it's reasonable thinking that a low volume is potentially associated also with a low implementations of innovative treatments. That is another issue. For example, minimal invasive surgery. It has been shown and demonstrated that minimal invasive colorectal surgery is able to deliver the same oncological curative resection as traditional open surgery. Indeed, minimal invasive surgery is likely to give better oncological results due to the lower impairment of the immune system. But again, as you can see, this approach is not equally in my nations provided in all the hospitals treating colorectal cancer. And the problem of limited access to innovative practices doesn't only concern surgery, but also clinical pathways. I don't know how many of you know the Enhanced Recovery After Surgery program in colorectal surgery, but this program was described for the first time in 1997. And it's based on the multidisciplinary evidence-based interventions before, during, and after surgery. And the purpose is to mitigate the negative, the undesirable effects of the surgical stress response. The description of this approach was a revolution when it was introduced, because it represented a very important shift from the exclusive focus on the disease, the so-called doctor-centered model of care, to a broader considerations of the illness experienced by the patients, including also the psychosocial components. So the patient-centered model of care. And after 20 years, we can say that it has been demonstrated that this approach, after major colorectal surgery, can really reduce complications, improve recovery, and shorten length of stay. But again, despite these proven benefits, ERAS protocol is still not mainstream practice. Many surgeons in Italy, in Europe, all over the world claim that they do ERAS, but implementations on large scale is absolutely slow and patchy. not only in Italy, as you can see in this bubble map, but all over the world. The barriers are many, probably inadequate knowledge, inability or wish to change, the lack of clinical leadership, but I think that at least in my nation, another reason, another explanations could be the excessive number of hospitals that treat colorectal cancer with a low case load. Just for giving you an example, these are personal data, my series from 2015 and 2020. Just to tell you that the combinations of innovative, both surgical and clinical procedures can provide better results also in terms of savings, just because it gives us the opportunity also of an early discharge. Early discharge means sometimes 48 or 72 hours after surgery. And these approach, these combinations in this series, when more than 80% of patients received minimally invasive surgery, when more than 80% of patients received this clinical pathway, the ERAS protocol, this experience shows that we increased our early discharge up to 30% in 5 years, and we start from 0% in 2015. And the explanation is that ERAS protocol takes care of the person who has colon cancer and not a person's colon cancer. I think that this is a very substantial difference. And it does it just, for example, paying close attention to the preoperative conditions of the patients. For example, the preoperative nutritional status. Malnutrition is associated with increased postoperative morbidity. All the patients should be screened to detect malnutrition, and those with higher nutritional risk should receive preoperative nutritional support. And that's what we did. In this, our study, we compared the patients treated with minimally invasive surgery and standard ERAS protocol with patients who received nutritional support. And they were screened and they received nutritional assessment, personalized diet 3 weeks before admissions, and then a reassessment the day of admissions, postoperatively, at discharge, and even after 1 month after surgery. And what we found that postoperative complications were significantly lower in the nutritional group, with a significant reduction in long-term stay. And we made also a deterministic analysis on the basis of real data for our populations. And what we found is that there could be a significant reductions even of cost, considering both hospital stay and complication associated cost. And globally, if we consider 1,000 patients treated with colorectal surgery, maybe the savings could be more than 3 million euros. And I think that it's a very important issue in terms of sustainability. So in conclusions, I believe that as it happens with breast cancer, one of the key points in fighting colorectal cancer is a wide implementations of colorectal units. I think that we need colorectal units all over the Europe, because I think that it's the only way, or one of the best way to guarantee all patients to be treated in multidisciplinary centers with a certain annual number of cases, where audit, performance measurements, quality assurance of outcomes are periodically made, and patients in these centers could be involved in every step of the decisions-making process. And this is, I think, a great job for the patient support organizations. And this is what EuropaColon Italia is going to do for our Italian patients, and in collaborations with Digestive Cancer Europe. Thank you very much for your attention.